Hello, my name is Rebecca Pettit, and I'm the Pediatric Pulmonary Ambulatory Care Specialist at Riley Hospital for Children at IU Health in Indianapolis, Indiana. And today I get to talk to you about difficult to treat organisms, specifically in Cf exacerbations. I have no relationships to disclose with regards to this presentation. So really my objective for today, since it's a 25-minute talk, is to describe appropriate management of acute pulmonary exacerbations of MDR organisms. Specifically, I'm going to talk about a Chromobacter, Cenotrophomonas, and Burcaldaria. Really, to cover all the MDR organisms you may see in CF patients would be way more time than I have allotted for this. And also, Kevin is going to be covering Mrsa infections in his talk, so I won't talk about that today. So just to add some context, this is the 2018 CF Patient Registry report. And you can see there I have highlighted Cenotrophomonas, a Chromobacter, and Berkelederia Sepatia complex, and the percent of individuals based on what year. So this starts in 1992 to 2018. So you can see Steno is that red line, a Chromobacter is the purple, and Burcaldaria Sepatia is that yellow line at the bottom. So really all of these three organisms are in less than 20% of individuals with CF, and which is great because these bacteria are inherently drug resistant. So you may not see them commonly in your practice. This is the prevalence of these organisms with regards to age. So you can see Burcaldaria and a Chromobacter, fairly uncommon in the younger age group and gets a little more prevalent with age, increasing age. Cenotrophomonas kind of hangs out in its own little pattern, kind of regardless of age there. You can see in that purple line. So just to start out with a little background on CF exacerbation. So this study looked at over 18,000 patients, and they included pulmonary exacerbations, which they defined as increased respiratory symptoms or clinical worsening in pulmonary status. Again, the exact definition of a CF exacerbation is something that is debated, but that is the definition they used. They looked at clinician-initiated antibiotic therapy and made sure that all exacerbations were separated by greater than 14 days. So I bring this up because this study broke down what percent of these exacerbations were treated with inhaled, IV, or oral antibiotics. And you can see the vast majority were treated with oral antibiotics, followed by IV antibiotics, and then inhaled. We will touch on all three of these different forms of antibiotics today, but just keep this in mind. And I think, you know, as we think about exacerbation treatment in a Trikafta era, we're going to be looking probably at more oral antibiotic treated exacerbations, hopefully in the future. You can see on the right side of the screen is the average exacerbations per year with the different age groups. And you can see, you know, highest in the less than 6 years of age, and then 6 to 12, not as many, and then going up in our teenager, young adult years, and then falling in our older patients. So I like this part of the study as well. You can see in the patients what their best FEV1 in the year prior to treatment was, and if they received IV, inhaled, or oral IV antibiotics for their exacerbation. And you can see definitely we treat our more stable patients with oral antibiotics, and then inhaled, and then IV for our sicker patients, which is what you probably see in your practice. So no talk about multi-drug resistant organisms would be complete without talking about antibiotic susceptibility and its correlation to clinical outcomes in CF. And I think this is an important point. If you don't take away anything else from this presentation, this is what I want you to take away from it. This systematic review in the Journal of CF is worth a look if you have not looked at it. So they looked at the available literature looking at antimicrobial susceptibility and exacerbation response. They only found 2 studies that actually showed a correlation between antimicrobial susceptibility of the organisms and response, and 11 that did not show a correlation. So keep that in mind. So the majority did not. We'll cover the 2 that did, but I think this is an important point because it kind of goes against everything we learn as in pharmacy school or maybe in residency and all those ID principles, that even though the susceptibilities say resistant, our CF patients can still respond to that antibiotic and have a positive clinical response. So I challenge you to kind of go against the grain there when you need to, and I think it's important when we're talking about multi-drug resistant organisms to keep that in mind, that even though it may say resistant, the patient may respond to an antibiotic that is resistant there. So the first study that showed correlation was a prospective crossover study of continuous versus intermittent IV Ceptazine. It only included 28 patients, so not a very large study. You can see there, you can see the difference in intermittent versus continuous in susceptible isolates. So not a significant FEV1 change. However, when you look at the resistant isolates, they did find a significant change in FEV1 in those patients that received continuous Ceptazine versus intermittent. The second study looked at 452 exacerbations treated among 101 patients, and they found an inverse correlation between treatment failure rates and number of antimicrobials used. So you can see less antibiotics, potentially more failure, more antibiotics, so 3, no failure. However, if you look at the patients, there's only 3 patients in that 3 antibiotic group, so really not that many. Again, 11 studies suggested no correlation between antibiotic susceptibility and exacerbation outcomes. So I preface this that I'm going to talk about antibiotics that are commonly susceptible for these organisms that you might want to start with, but again, don't be tied to your susceptibilities when you don't need to. They're great as guides, but don't let it be the end-all be-all, as your patient may respond to an antibiotic that they are resistant to. All right. So when we talk about multi-drug resistant organisms, we definitely need to talk about optimizing antibiotic dosing. And I don't have time in this presentation to go through this in depth, as it could be its own presentation. But some of the overarching principles I want you to think about is once daily aminoglycosides, make sure you're optimizing your dosing and monitoring parameters there. Beta-lactams, as we just talked about, that Ceptazine study, if you have a resistant isolate, you may want to look at prolonged or continuous infusions, and if you have the ability, potentially beta-lactam levels for those patients may be beneficial. And then optimizing other antibiotic dosing based on the pharmacokinetic and pharmacodynamic changes in the CF patient. So I'll point you to great review articles in pediatric pulmonology that were written by by Dave and Jeff there. You can see the citations at the bottom of the slide. They cover your different antibiotic classes and are a great look at what dosing is out there in CF patients and what you might want to consider there. So now for our first organism, so a Chromobacter. So it is a gram-negative organism. It's an environmental opportunistic pathogen. And you'll kind of see that's a little bit of a trend here in these three I'm going to cover today. It has innate antimicrobial resistance, but also acquires resistance with different antimicrobial exposure, which leads to altered gene expression to promote chronic infection, and we often see this in our CF patients. The most common Chromobacter we see is Chromobacter xyloxoxazans, and clinical consequences of this organism, there's actually conflicting studies. So some studies would point to this organism as causing lung function decline, and others do not. So it's really conflicting in the literature if you look at this organism. We do know that it increases the host inflammatory response, which may be particularly detrimental in some of our patients. So what antibiotics can we use to commonly treat a Chromobacter? So the most common active antibiotics to a Chromobacter are carbapenems, piperacillin-tazobactam, ceftazidime, sulfamethoxyl trimethoprim, minocycline, doxycycline, and colistin. So I think these are great places to start when you're looking at treating a Chromobacter. Obviously, if your lab has the ability to do susceptibility testing, definitely take advantage of that and use that information to help guide your selection. There's not really data out there to suggest whether you should single cover or double cover a Chromobacter. And to be honest, I've seen a variety of different practices in my years treating CF patients. So, I think a lot of these antibiotics can be used to treat other organisms the patient might have, whether they be Pseudomonas or other things. So you may be able to double dip and cover two organisms with one antibiotic, but also keep in mind if you do want to double cover, trying to get an antibiotic with a different mechanism of action when you do the double cover. But by all means, you do not, there's not evidence to support that you need to double cover, so you could use single cover agents. So I commonly use in the outpatient setting sulfamethoxyl trimethoprim to cover this organism, as well as some tetracyclines. And then when we're thinking about inpatient, depending on susceptibilities, just using, Ceftaz or piperacillin-tazobactam. And then if I'm also targeting Pseudomonas, I've already got my aminoglycoside on board as well. That may or may not cover the Chromobacter depending on your susceptibilities. The next organism is Stenotrophomonas multifilia, which is a mouthful, right? And a lot of my patients refer to as the dinosaur bacteria. So it's more common in patients with lower baseline lung function, and it's really unclear in the literature if it's a significant pathogen or if the infection is a marker for severe lung disease. So again, just like a Chromobacter, there's conflicting studies on the impact of lung function decline in CF patients and whether you need to treat this organism or not. In some patients, you may not need to treat this organism, and in others, it may be an organism that you need to cover to get a clinical response. There's been different Cochrane reviews throughout the years, and the most recent one showed no evidence in the literature regarding the effectiveness of antibiotic treatment for this organism. when I looked back at the Cochrane reviews through the ages, there really hasn't, there's been some new data on this organism, but not a lot. And so it doesn't really help us guide our treatment. Really, the conclusion of that Cochrane review was to decide to treat on a case-by-case basis. Some patients may warrant treating the Stenotrophomonas, and others may be fine if you don't treat it at all. So again, using your susceptibility testings to help guide, but if you don't have those available, common antibiotics that typically work for Stenotrophomonas, so doxycycline, levofloxacin, sulfamethoxazole, trimethoprim, and colistin. Again, thinking about what you can use in different patient scenarios. This is an organism that we sometimes see in our younger patients. So just a note, I'm sure you guys all know this because you're pharmacists, but use of the tetracyclines less than 8 years of age, you want to be careful with regards to teeth discoloration. So be thinking of that when you're selecting these different possible antibiotics for your patient. And last but not least is our Burcaldaria Sepatia complex. So there are over 20 different species of Burcaldaria Sepatia. And I feel like this is a hard thing when I have residents or students. They see Burcaldaria and they're like, oh no, that's the feared organism in CF. But there's different species, and the different species have different virulence and impact patients in different ways. It is an environmental pathogen, so patients can definitely pick it up in the environment depending on what their environment microbiome consists of. So I listed on here some of the commonly seen species in CF patients. So Burcaldaria Sepatia, Burcaldaria multiviridans, Burcaldaria Cenocepatia, dolosa, and gladioli. So multiviridans and Cenocepatia represent about 85 to 97% of Burcaldaria Sepatia complex infections in CF patients, and are thought to be our more virulent organisms that we really want to watch out for. The other Burcaldaria, definitely something to keep an eye on, but these two, the multiviridans and the Cenocepatia, you want to be very mindful of when you see those. So treatment for Burcaldaria. So if you look in the literature, there's a lot of different information on people who have tried different Burcaldaria eradication protocols with varying degrees of success, both in the US and in other nations as well. So you can find, a lot of small reports and case reports in that area if you're looking for to eradicate Burcaldaria Sepatia. There's really nothing that points to this is the regimen that works for everyone and is the recommended regimen like we have with Pseudomonas, our inhaled tobramycin. We know exactly what to do to try to eradicate that organism. That isn't the case with Burcaldaria. So if you are going to try eradication, I encourage you to go look in the literature, see what other people have tried with varying degrees of success, and kind of adapt it to what would work best for your patient as far as side effect profile and safety as well. When we think about exacerbation treatment and the treatment of Burcaldaria in an exacerbation setting, the most common active antibiotics, Ceptazine, meropenem, sulfamethoxazole, trimethoprim, minocycline, doxycycline, and then some of our newer agents, ceftazidime, avibactam, and piperacillin, avibactam. There are case reports with those last two showing treatment of Burcaldaria in CF patients with those agents. So if you're going to use some of those, there's case reports out there to help guide you. But again, not a whole lot of options for this bacteria. It is inherently resistant, and so a lot of people double cover Burcaldaria, and it can be difficult to double cover this organism when you're selecting, antibiotics with different mechanism of action to find something that is susceptible. So sometimes you may have to, if you do want to double cover, use an agent that may be resistant and see if you can get a clinical response with that combination. I do want to point out this study of inhaled aztreonam for patients with chronic Burcaldaria. This was a double-blind, placebo-controlled 24-week trial of continuous inhaled aztreonam, 75 milligrams inhaled 3 times a day compared to placebo. It enrolled 100 patients. However, it did not find a significant change in FEV1. However, they did find a median time to next exacerbation was 24 days less in the aztreonam group, although it wasn't statistically significant. So inhaled aztreonam has been used in a lot of eradication protocols for Burcaldaria and may be an option for patients, whether this is in the acute exacerbation setting or as chronic therapy for those patients that have difficulty with this organism. Keeping in mind that they didn't find an FEV1 change, but a time to next exacerbation of, about a month, a little less than a month less is not bad, potentially in some of these patients that are pretty sick and have exacerbations frequently. So this is a potential option for patients. So the last thing I want to talk about is phage therapy. And so this could be a whole talk in itself, and I think is something really interesting and up and coming in the microbiological ID field, not only for CF, but other diseases as well. So this is where bacteriophages, which are viruses that can infect bacteria, are produced to specific strains of bacteria and then are used to treat patients with that bacteria. There is a case report in the literature of a CF patient with a Chromobacter xyloxanes that was treated successfully with phage therapy. And these are potential options in the future for multi-drug resistant bacterial infections in our CF patients. And I think we'll see more, studies or case reports or use of this in the future as we look at different options to treat these patients that still have these multi-drug resistant infections that need proper treatment. So with that concludes our overview of multi-drug resistant organisms, so Chromobacter, Stenotrophomonas, and Burcaldaria. Again, hopefully I gave you some big overarching guiding principles to guide your treatment of these organisms in CF patients. By all means, please use the listserv if you're new to this and need some help. There's those of us that have been doing this for years are happy to help guide you that may have seen this bacteria or a certain patient population that you're running into. So please reach out if you have questions or need help as a pharmacist community. We're definitely happy to help others with treating these patients, as these can be difficult and complicated to treat. So there is my email address. If you have any questions, feel free to email me or it looks like in our paperwork, there'll be chat functions or other networking opportunities throughout the conference. So feel free to message me there, and I'm happy to chat more.
Hello, my name is Kevin Epps. I'm an antimicrobial stewardship pharmacist at Mayo Clinic in Jacksonville, Florida. And before I start, I just want to thank the planning committee for this opportunity to present. I will be talking about challenging pharmacotherapy issues across the CF continuum of care. Most specifically, I will be talking about the optimization of anti-Mrsa agents in the treatment of Cf exacerbation. I have nothing to disclose. The objectives of this presentation are to describe the clinical impact of Mrsa in cystic fibrosis. We will evaluate the literature of Mrsa treatment in cystic fibrosis, and we will also discuss therapeutic options to treat Mrsa infections in cystic fibrosis. Staphylococcus aureus, when you look at it under a microscope, looks like grapes. It can be either methicillin susceptible Staph aureus or methicillin-resistant Staph aureus. Staph aureus commonly colonizes the nares and also the skin of healthy individuals, but we run into problems when we start to have an active infection with Mrsa or methicillin susceptible Staph aureus. I added this slide just to remind us all that antimicrobial agents have target sites. Fluoroquinolones bind to DNA gyrase, aminoglycosides bind to the 30S subunit of the 50S to prevent protein synthesis. But I'm going to concentrate a little bit now on the cephalosporins and the monobactams. What happens in MRSA is that these organisms have a MECA gene inside a staphylococcal chromosomal cassette that confers resistance to the cephalosporins and the monobactams. Remember, the bacteria are going to make their cell wall by first making N-acetylmuramic acid, then N-acetylglucosamine, and then the third step is going to be that transpeptidation, which is going to cross-link the N-acetylmuramic acid and the N-acetylglucosamine. So the way the cephalosporins work is they're going to bind to those penicillin-binding proteins on that third step, inhibiting that transpeptidation. So what happens in Mrsa is that there is a MECA gene, like I said before, that confirms resistance, so the cephalosporins are no longer able to bind. And since they cannot bind, they're no longer treatment options for methicillin-resistant Staph aureus. The only cephalosporin that can be used for Mrsa at this particular time is Cephteraline, and we'll talk about Cephteraline a little bit later. The problem also with Mrsa is that since you eliminate relatively a whole class of antimicrobial agents, it limits the amount of agents that you can use to treat methicillin-resistant Staph aureus. So what's this clinical impact of Mrsa in cystic fibrosis? Well, when you have methicillin-resistant Staph aureus, it's associated with the more rapid lung function decline. It's also associated with worse lung function. And there's also an increased risk of not recovering baseline lung function after an exacerbation. So that's why it's very important for us as clinicians to make sure we optimize our agents as much as we can so we can hopefully return our lung function back to baseline. Because we know if we don't return back FEV1 back to baseline, that's potentially lung function that's going to be potentially lost forever. Methicillin-resistant Staph aureus is also associated with worse survival. Now let's take a look at the prevalence of Staph aureus and methicillin-resistant Staph aureus. You can see Staph aureus with the green line. You can see it's isolated a lot younger in life, and then it starts to plateau at about the age of 11 to 17, and then by the age of 18 to 20, it starts to decrease. Well, as Staph aureus decreases, you can see at the age of 11 to 17, Mrsa starts to increase, and then by the age of 18 to 24, it starts to plateau, and then by the age of 25 to 34, it starts to decrease. So this survey was sent out to all the accredited CF centers in the United States, and it was really sent out to see what agents we're using for Mrsa, and also to figure out what doses we're using for these particular patients. There was about an 80%, about a 60% response rate to this survey, which represented about 80% of the adult CF and pediatric accredited centers in the United States. So even though it had about a 60% response rate, it had about 80% of the centers in the United States, which really gave us a good idea of what CF centers were doing across the country. So on the outpatient setting, as you can see, Bactrim was the most commonly used antimicrobial agent in pediatric patients and also adult patients at a dose of 5 to 40 milligrams per kilogram per day, divided every 8 to 12 hours. And for adults, 160 to 320 milligrams every 8 to 24 hours. The next most commonly used agent in the outpatient was Lynasolid, then followed with doxycycline. So this kind of gives us a good picture of seeing that about a third of the patients are prescribed Bactrim in the outpatient, a third Lynasolid, and then a third other antimicrobial agents. When we move to the inpatient setting, vancomycin IV is the most commonly used IV antimicrobial agent. However, when you take into consideration IV Lynasolid and oral Lynasolid, those make up the majority of agents used for treating Mrsa on the inpatient. So about a third of the patients use Lynasolid on the inpatient setting, a third vancomycin, and a third other agents in the inpatient setting. So let's start talking about our agents. Let's first start with vancomycin. Vancomycin is a member of the glycopeptide class of antibiotics. Its spectrum of activity includes various gram-positive aerobic and anaerobic organisms, and it's also going to inhibit cell wall synthesis by binding to the glycopeptide binding protein. So looking at the Pkpd studies for vancomycin, we first start with Pleasance that had 10 CF patients that were adult patients that received 15 milligrams per kilogram IV times 1 of vancomycin within 72 hours of an admission as part of an acute pulmonary exacerbation, including Mrsa, and 12 blood samples were obtained from that one dose. And what they were able to find out from this study is that the kinetic results were consistent with previous studies of healthy volunteers, and that CF does not alter vancomycin kinetics. Why they maybe found that CF does not alter kinetics is maybe because these patients were potentially older. That's one thing that comes to mind. We look at the study by McDade. She looked at 90 treatment courses of vancomycin retrospectively for patients 11 months to 20 years old at a dose of 60 milligrams per kilogram per day divided Q6. And her findings were that the 60 milligrams per kilogram per day divided Q6 did not achieve a therapeutic trough of 15 to 20, and that higher doses may be required in younger CF patients. A study by Durham et al. Included 31 CF peds patients that represented 40 admissions. These patients were started on 45 to 100 milligrams per kilogram per day, initially of vancomycin. Then, once they adjusted these doses for troughs, the range ended up being anywhere from 50 to 120 milligrams per kilogram per day. And in this particular study, they found no correlation between vancomycin dosage and trough. However, in a subset of patients, they found that if these patients were greater than or equal to 12 years of age, there was a correlation between vancomycin dosage and trough concentrations. Amin et al. Used a model to try to accelerate the desired trough in CF patients, and they looked at a dose of about 42 to 84 milligrams per kilogram per day. And this model showed us that daily doses of 80 milligrams per kilogram per day were needed for pediatric patients between 5 and 55 kilograms to obtain a trough of 20 milligrams per liter. Looking at just one efficacy study for vancomycin, there are others out there, but for the sake of time, I just wanted to include one. And I had decided to include this one just because it was only 3 patients, but these were patients that were dosed with vancomycin by the conventional method, and they were not able to reach therapeutic trough levels. However, once they used continuous infusion at a dose of 31 to 50 milligrams per kilogram per day over 24 hours, they were able to achieve therapeutic trough concentrations between 15 and 20. What you can see is with case 1, this patient was weaned off oxygen by day 3 and discharged on day 6. And the next exacerbation was 4 months later versus this patient having exacerbations every 2 to 3 months. Case 2, there was no change. And in case 3, you can see that supplemental oxygen was stopped after day 4. And the next exacerbation was 2 months versus monthly. So that's something for us to keep in mind. If we're not able to reach our therapeutic trough concentrations with vancomycin, maybe potentially before switching agents, maybe we can use a continuous infusion in those particular patients. So using the most recent literature that we have to date, vancomycin dosing for pediatric patients should be dosed around 60 to 80 milligrams per kilogram per day divided every 6 hours, and 30 to 45 milligrams per kilogram per day for adults divided every 8 to 12 hours with the maximum dose of 4 grams, considering that these patients have good renal function. And then once you get your first set of levels back, then you can always adjust your kinetics for those patients. 80% of patients said that they used a target trough of 15 to 20. And also remember, if you're doing AUC dosing, you want to aim for an AUC to MIC ratio of greater than 400. Moving to Lynasolid. Lynasolid has gram-positive spectrum of activity covering Enterococcus, MSSA, Mrsa, and it's going to inhibit protein synthesis by binding to the 23S ribosomal RNA of the 50S subunit. Looking at Pkpd studies for Lynasolid, Santos included 10 CF children who received 14 courses of Lynasolid. These patients received a dose of 10 milligrams per kilogram IV Q8, and no patient achieved an AUC to MIC target ratio of greater than 80. So the recommendation was to increase the dosing to 15 milligrams per kilogram per dose every 8 hours to achieve a target AUC to MIC ratio of greater than 80. Sepatia, which included 11 adult CF patients, were dosed at 600 milligrams orally every 12 hours for 6 doses, and the sputum concentrations were greater than the Mrsa MIC 90 for 12 hours, and the serum concentrations were greater than the Mrsa MIC 90 for 80% of the dosing interval. Taking a look at the Pkpd study by Basso, which included 12 adult CF patients, these patients received 600 milligrams IV times 1 dose, and by using computer modeling, they were able to say that no patients would have received a target AUC to MIC ratio of 83 for Mrsa MIC of 4, and that more frequent dosing may be needed for patients with inadequate clinical response. Looking at Lynasolid efficacy studies, they all look pretty good. You can see that the outcomes in Santos, all 10 patients improved clinically. Looking at the study by Farron, these patients had resolution of symptoms, and also looking at the study by Sarah Sear, these patients also had resolution of symptoms of pulmonary infection. So looking at our most recent literature, Lynasolid dosing for pediatric patients should be dosed at about 30 to 45 milligrams per kilogram per dose, divided every 8 hours, and for adults, 600 milligrams every 8 hours, with the maximum dose of 1,800 milligrams per day. Bactrim, or sulfamethoxazole trimethoprim, is a combination of 2 synergistic antibiotics. It has a wide spectrum of activity. When you look in the Sanford guide, it has spectrum of activity or activity for greater than 20 different organisms. And the mechanism of action is that the sulfamethoxazole and the trimethoprim are going to work synergistically. The sulfamethoxazole is going to prevent the formation of dihydrofolic acid by competing with PABA by blocking bacterial synthesis of dihydrofolic acid, and trimethoprim is going to interfere with the production of folic acid. There's only one Pkpd study involving Bactrim, that's Reed et al., that included 14 CF patients. There were 6 boys and 8 girls. These patients had a mean age of 18 years of age. And they did this in 2 different study situations. First, they did a single dose study. And when these patients came in, they received 1 oral dose of Bactrim DS. And then they obtained blood levels for these particular patients. And they looked at the kinetics of the Bactrim. They also, on a separate occasion, had these patients come in and they received Bactrim DS, 1 tablet every 8 hours for a minimum of 5 days, and they also obtained blood levels on these particular patients. And what they realized was that these patients had a shorter half-life and higher total body clearance for both agents, the sulfamethoxazole and trimethoprim. And the recommendation was to increase the dosing or decrease dosing interval in CF patients. When it comes to efficacy studies, there are currently no published efficacy studies regarding the use of Bactrim for the treatment of acute pulmonary exacerbation in patients with CF colonized with Mrsa. So using our most recent evidence, looking at dosing Bactrim in pediatric patients at 15 to 20 milligrams per kilogram per day, divided every 6 to 8 hours for IV and oral, and dosing adult Bactrim at 160 to 320 milligrams every 8 hours. Now moving to our agent Cephteraline, which is probably the newest agent, which is a 5th generation cephalosporin. This agent is going to have activity against gram-positive organisms, so that being methicillin-susceptible Staph aureus and also methicillin-resistant Staph aureus, and it also has activity against gram-negative bacteria. Unfortunately, not against Pseudomonas, but it does have gram-negative bacteria. Its mechanism of action is going to be, just like we talked about before, it's going to inhibit bacterial cell wall synthesis, but in this particular case, for Mrsa, it's going to have a strong affinity for the PBP2A, or that penicillin binding protein 2A, which is going to show that's why it's going to have activity against Mrsa, where the other cephalosporins don't. It also has great activity against strep pneumo as well, because it has a strong affinity for the penicillin binding protein 2X. Looking at the Pkpd studies for Cephteraline by Barsky, this involved 7 patients. These patients were greater than or equal to 6 years of age for a total of 10 courses of Cephteraline. And these patients received 15 milligrams per kilogram IV Q8 hours with a maximum dose of 600 milligrams. And this dose was adequately dosed to achieve greater than 60% time above the MIC for the dosing interval. The other study by Autry et al. Involved 8 adult CF patients, and the first 4 patients were dosed at 600 milligrams IVQ 12 hours. When these patients received blood samples at 2 and 6 hours post-infusion, they realized that the half-life was very short in these particular patients. So for the last 4 patients, they dosed it at 600 milligrams IV Q8 and realized that 600 milligrams Q8 should be considered to achieve greater than 60% time above the MIC for the dosing interval. So using our most recent literature for Cephteraline, pediatric dosing at 10 milligrams per kilogram per dose, divided every 8 hours and infused over 1 to 3 hours, and adult doses 15 milligrams per kilogram per dose with a max of 600 milligrams every 8 hours over 1 to 3 hours with a maximum of 1800 milligrams. And Cephteraline being a cephalosporin, I really recommend that you dose these over 3 hours if possible. That's just another way to optimize therapy in these particular patients and to potentially increase time above the MIC. So in closing, I'd just like to say I wasn't able to go over all the anti-Mrsa agents, but I was involved in a review article, and you can pull this now, it's available. But as you can see, there is a chart that gives all the evidence-based dosing for all the anti-Mrsa agents. We didn't get a chance to talk about the fluoroquinolones, but keep in mind that the fluoroquinolones are a risk factor for Mrsa resistance. There's a rapid resistance that develops with the fluoroquinolones. When we sent the survey out, some centers were using fluoroquinolones. I'm not exactly sure if that was because of allergies to a lot of the other medications, but I really highly discourage the use of the quinolones if you cannot use them for Mrsa specifically. I know sometimes as these patients get older, they are colonized with Mrsa and Pseudomonas, so sometimes you'll be using your quinolone along with a beta-lactam on aminoglycoside for Pseudomonas, but just for Mrsa, I definitely do not recommend using those. There's also some data for the tetracyclines as well, and also clindamycin, so that article's available for you to download and to review, to use in your clinics and use in your hospitals to try to optimize antibiotic dosing for our patients. In conclusion, Mrsa may have a significant impact on the clinical outcomes of CF patients. Mrsa is definitely a growing problem in CF, and more studies are needed for optimal dosing in CF. As you all know, the pipeline is really dry for newer antimicrobial agents. So what we have now is probably what we're going to have for a while. So it's very important that we optimize our doses as best as possible. Thank you and have a great day.
Hey, thank you everyone for attending NACFC 2020 in this virtual format. And thank you for attending this session. Challenging pharmacotherapy issues across the CF continuum of care. I am Justin Moss. I am a pharmacy technician with Primary Children's Cystic Fibrosis Center. I have been a technician now for almost 15 years, and I've been with Primary Children's Hospital now for just over 7. And I have been full-time technician in the CF Center for about 1.5 years now. And today I'll be talking on the addition and implementation of a pharmacy technician into an established CF team. I have nothing to disclose, and with that, we'll go ahead and get started. So, what exactly does the addition and implementation of a pharmacy technician into an established CF team look like? Well, first of all, obviously you have to have your CF team, and then you get the approval to go ahead and add a pharmacy technician, hopefully to work alongside the pharmacist that's already with the CF team. So, first you need to have a technician. Oh, and look, there's one right now. That is actually me with my wife on a trip we took last year for our anniversary. So now we have our technician, and we are going to add him into our CF team. So here is our CF team here at Primary Children's last year at NACFC. So look at that, you've got your team there, and look, there I am. Simple as that, right? You take your technician, you add them into your team, and then there you go, done. But maybe it's not as simple as that. So you have your technician, you've got him now in your team. So now, what are some things your technician can do? So here is a list of some ideas and some duties that you can have a clinic-based pharmacy technician do for your CF team. So the first one, and yes, it is a big one, PA submission and assistance. I know there are several centers across this country that have a technician that this is their primary role due to the fact that there's just so many PAs that have to be done when it comes to cystic fibrosis drugs, as we all know. So this is always probably be at the top of anybody's want list and should always be towards the top of any type of list that you may want to put together for things your technician can do. In my case, I actually do not do a lot of submissions, but I do a lot of assistance, as in I will get PAs started and get submitted to our PA team, and then they will from there go ahead and submit those PAs. But if there's any type of information that is needed or any type of clarification, they will reach out to me and I will help assist with that. Another big thing that you can have them do is copay assistance. We all know this can be a huge thing and can be very tiresome and can take a lot of time trying to get your patients enrolled and the Vertex GPS, enzyme programs, grants, etc. Now, this may not be something you need to do all the time, but it is something that will also be pretty high on the list of things that you can have a technician do if they're not already doing it. Another one is medication history. Now, this is not to be confused with medication reconciliation, but history. If your system allows your technicians to be able to do medication history, this can actually be a really big help in being able to make sure that the medications in your electronic medical record are all up to date and that their doses and their directions are all correct. Another one is benefit investigation. Now, this can come in many different forms, whether it is as simple as trying to figure out where a medication needs to go. Maybe it's calling the insurance to ask where a certain medication needs to be filled. In my case, I am actually able to run test claims through Enterprise RX through our outpatient pharmacy at the hospital to be able to not only find out if something is covered, but what their copay may be, and again, where medications may need to go. Now, this is something that we at our center call pre-clinicking, or this is something that me and my pharmacist, Jeff, call. And this is something that I actually do on a weekly basis. So this is just looking at the patients for the next week and doing a couple items, such as refill history, refills that may be needed, keeping track of labs and eye exam. I know some centers actually will have their technicians kind of keep track of what labs may be due, and this will help alleviate some of the stress and maybe some of the time on pre-huddling for the nurses and for the providers. So this is an idea that you might be able to do ahead of time, is just keep track of these different things, or if they've had an eye exam, when it may be, or if they're due for one. And also to address any known issues, whether it may be refill history, maybe it's not looking as good as it should. Maybe there's a little bit of issues either with the pharmacist they're phone with, maybe there's insurance that has been lost, or maybe they're just not taking medications. But there's lots of different things that could be addressed this way. And if you are either talking to your patients, talking to the pharmacies, or any various different ways of your pre-clinicking, this is a good way to actually just kind of jot down things to let either your pharmacist know or maybe your team know. Now, looking at this list, this is a pretty good comprehensive list, and especially if you look at just PA submission and assistance, this could take up a very large portion of a technician's day, whether they're full-time or part-time. This could take, this could be a full 8-hour shift on some days. So I'm looking at this and be like, okay, this is a really good outline for what I can have my technician do, whether you have one established or maybe you're about to get one. But also, think about these ideas. Quality improvement. I know a lot of our centers have quality improvement teams. Maybe they're part of the CFLN, or maybe they just do it on their own. I am actually the pharmacy portion of our quality improvement team here at Primary Children's. It actually started when I visited another center and actually learned more about what they were doing for their quality improvement teams. And when I came back, I realized that we had a team. So at the time I did not know this, but they were asking for any ideas or volunteers, or if anyone just wanted to sit in on a meeting to find out what the quality improvement team did. So I had an idea that maybe might be able to help our center on some pharmacy-based issues. And so I attended the meeting and brought it before them and gave them some ideas. And after that, I was asked if I would actually like to join the quality improvement team. So now I am the pharmacy portion of our quality improvement team. Another thing is transition. Whether you have a transition team that you could be a part of, or maybe just to assist your nurses, your nursing coordinators, or maybe another center that's needing information, this will be a good way to have a technician maybe pull some information. Maybe they just need refill history. But this is a really easy thing to have them do that can be added on, that maybe it's not a day-to-day thing, but just maybe it's a once-a-month thing, or maybe just an as-needed thing. But this can also be another idea that you could have a pharmacy technician do. Now we have main contact for specialty concierge. Now this meaning for the specialty pharmacies, some of them have concierge services for our CF centers. If you do not have a specialty concierge set up for your center, I highly advise getting a hold of Accredo, CVS, and Alliance Walgreens and asking them if you can be set up with your own concierge. Some of the other specialty pharmacies, like Kroger and Foundation Care, I believe, are also in the process of getting this worked out. So this will be a good thing to have your technician do. Just reach out, one, ask if they have one, and two, get your center signed up and maybe have them be the person that is that main contact. I would recommend both technician and pharmacist being that main source of contact, but maybe most information will be getting sent to and maybe addressed by your technician. This is actually a really nice thing to have. Then you have a direct contact to these specialty pharmacies. If there are any issues with insurance and billing, they can get a hold of you really easy. If maybe something got billed incorrectly and now all of a sudden your patient has a $2,000 copay on one of their modulators, this could be a really quick fix with just a simple email, just asking, hey, can you check this out? Maybe a grant didn't get ran, maybe the copay didn't get ran. So this is a really quick and easy way to make things work a little bit better with your specialty pharmacies. Refill requests. Now I know some states and centers may not allow this for your technicians, but this, if it is, this can be a really nice thing where maybe all refill requests coming into your center, instead of it going to the nurse triage or maybe a call line or get sent to whoever it may be to take care of these, maybe all those refill requests come in, they go directly to you, and then you can send them directly to the providers or however your system is set up. That's another big one, refilling medications, whether it be on-site or off-site. Now this could be a technician that works in a specialty pharmacy. Maybe they are dedicated to doing just CF meds. So this can be something that can be used to fill prescriptions, or in my case, what I mean by off-site is I don't actually work in the outpatient pharmacy, but I can actually set up refills through our outpatient pharmacy in the clinic, from home even, when I'm doing virtual visits, or to be able to help with if there's a billing issue. Maybe a patient called in to the outpatient pharmacy and something's not billing correctly. You can go in and look and say, oh, the health well has gone inactive, or they have the wrong ID, or something happened with the copay assistance. You can go in and actually fix these things. So this is another thing that actually can come in very handy, and it can actually tie into the benefits investigation that I talked about a little bit earlier. Insurance champion. So what exactly is an insurance champion? So this can, the way I look at it, as every year insurance changes. People always have a million questions on what should they switch to, what should they not switch to. Maybe there's an issue where there's a divorce and now someone has to take over the insurance, or there's a new job. This can be really helpful to your patients if they know that if they have questions, they can at least come to you and say, hey, could you take a look at this plan? Could you help me decide, maybe what the best plan is, maybe be able to read into some of that finer detail that as pharmacists and technicians were able to look at and know exactly what they're talking about, whereas our patients don't always know. You can be that champion for them to say, hey, can I send you this information? Can you look at it? Can you let me know what I need to ask my employer, what I need to ask our HR person, just to be able to help figure out what might be the best course of action for them, and also to be able to help pay for these very costly medications. Here's another one for pre-visit planning. This also can tie into, as I talked to earlier about the pre-clinicing. I know a lot of centers, ours included, do pre-visit planning. With our center, we actually, our nursing staff actually will send these out a week in advance to the patients just to ask if they have any questions. And, we're hoping that they'll fill out this little form and send it back to us so that we're aware of any issues or questions that they may have. So if your center has something like this set up, this may be something you can have your technicians actually look into, so that when these responses get sent back, they can actually be able to help address any pharmacy type questions, or maybe if they are doing a pre-clinic type of thing, that they can actually use this pre-visit planning to actually help with that pre-clinicing that I talked about. Or maybe your center isn't doing any type of pre-visit planning. Maybe if you have the resources, this could be something that could be set up that you could do, whether it be for your entire center, or maybe it's just for your just for the pharmacy team. Maybe this is just a good way to be able to do that med history ahead of time before they even come in, or talk about any of those known issues. This could be a form of like what we call that pre-clinicing. Now, this is just to name a few of the items that you could have your technicians work on. I'm sure I could probably go on for another 30 minutes on wants and wish lists from not just my pharmacist and my team, but from the rest of the teams across the country. So this is a little template that I use for our pre-clinicing or pre-visit planning. So this is something that I set up, and I have this little template where I will set it up by date for all the patients that we were going to be seeing, and then by the patient name, and then some of the information that I will add in and collect is their last fill. So this just is a way for me to be able to look and see when they last filled, if there's any type of adherence issues. I can leave little notes on where they last filled. So maybe they fill at their local grocery store for most of their items, but maybe they have their Pulmozyme and their modulator at, let's say, a Credo. I could say they filled at the grocery store on this date, and they filled their Trikafta a week ago, but they haven't filled Pulmozyme for 6 weeks. So this is a good spot where I can actually leave little notes for myself and for the pharmacist, just letting them know when they last filled. And then I put down refills. So this actually benefits us a ton. So what I'll actually do is look at the medications that our patient is on, and when was the last time we sent refills? We sent 12 refills 2 months ago. Well, if I look through their list and I can see everything, then I know, okay, well, we just sent refills, so they don't need any more. But maybe in 2 months from now, one of the refills we sent a year ago is getting ready to expire. This is a good time to renew a lot of these medications, and just lets either our team or in my case, let my pharmacist know that these are all refills that are going to be needed. And this will actually help save a ton of time and effort with the refill calls and pharmacies reaching out for refills if you're being a little proactive. So this actually helps us out a ton. And since I've started doing this, I believe our requests for refills has gone down probably, I'd say at least 50 to 75%, because we're being proactive on the refills that we are sending. And then the next thing I started tracking was eye exams. So with the eye exams, we know that all of our pediatric patients, if they are on a modulator, they are supposed to get an eye exam, or at least it's recommended every year. This is a good spot for me to be able just to kind of keep track of this on this pre-clinic or pre-visit planning sheet that I send to the pharmacist, just to let them know when their last eye exam was and if they may be due for one. And then another thing that we started doing is Trikafta start date. We were asked to start keeping track of when they actually started Trikafta. So now what I do is I look at past notes, or I look at refill history, or I'll call the pharmacy directly to find out when exactly they first filled it, so that we can start keeping track of this. So this is something that in our pre-huddles, when they ask if patient Y is on Trikafta, when did they actually start it? Well, now instead of having to go through the notes or try to find things, I have it right there for the pharmacist or for myself in these pre-huddles to be able to say, this is when they started it. And then I also keep track of HealthWell. That is the grant that we use 99% of the time at our center with our patient. So in going back to what I said earlier about the copay assistance, this is something that helps me and the pharmacist know when their HealthWell grants are due, when they need to be renewed, and then if we need the information to be able to renew it, I actually take on that responsibility of all of our patients that are on HealthWell renewing their grants and making sure the pharmacies have the correct information. So this is just a little way for me to be able to keep track of all that information, to be able to set it up, and so that we don't have issues with HealthWell grants going inactive. So now we have duties that a technician can do, and now we're looking at some of the things I do pre-clinically. So now what about actually in the clinic itself? So here is a flow chart that actually was just published in Pediatric Pulmonology by a pharmacist, Jeff. And as you can see, like, this is a very simplistic breakdown of what we do when we actually see the patient, whether it be virtually or in person. So you can see the patient is seen in the clinic, and then we do this medication history. And like I said, this could be done either beforehand, but we do it actually when we see the patient. That just works for our workflow. And then if there's any type of investigation that needs to be done that falls to me, so then I can find out if it's a new start, if it's a new insurance, or whatever it may be, I can find out where medications need to go. And as you can see, for our clinic, we have 3 main options. So the top one is ISP, Pharmacy Technician Manages Patient. That stands for Intermittent Specialty Pharmacy, and there is a technician, Stephanie, who also does is CF medications, and that is her job at the specialty pharmacy. And then we have PCH, which is Primary Children's Hospital, where clinic-based pharmacy technician manages patients. So if it's something that we can fill here at our outpatient pharmacy that cannot go to the specialty pharmacy and we are able to fill it, we will give them that option if they would like us to fill it, or if they would like to fill it with their local pharmacy or their specialty, or with their specialty pharmacy if that's where they're already filling medications. If it does need to go to a specialty pharmacy, then I will actually reach out to them to let them know that we're sending a new medication, whether it be a new start medication, or maybe it's just new insurance, and I'll reach out to them to coordinate that. So the part that I really want to talk about next is this section right here. Clinic-based pharmacy technician manages patients. So what exactly does that mean? Well, at our clinic, we have roughly around 300 pediatric patients that we see, and out of those 300, I fill for about 70 of them through our outpatient pharmacy. I am unable to fill modulators, but with some insurances that do not require them to go to a specialty pharmacy, I can fill Pulmazine, and sometimes on occasion we can do tobramycin and held. So I actually will manage their medications for everything that they have that is non-specialty, and I will work with the specialty pharmacies just to make sure that they are filling their specialty as well, or if there's any issues, they know they can reach me, or if I'm speaking with the patient's guardian, if there's an issue, then I can reach out to those specialty pharmacies as well. So this is a breakdown of how I manage my patients. So on the left-hand side is a little diagram, a little graph, if you will, of what I use to keep track of my patients. Now, I did not make this. This is actually from the specialty pharmacy, Stephanie. She actually is the one who created this. And when I started filling for patients through Primary Children's, I was able to borrow this from her, and I have it in OneNote. And as you can see, I have the patient's name, date of birth, who I need to contact, best contact, and then also best phone number. Sometimes I'll have 2 or 3 different phone numbers on there, depending on who I need to get a hold of. And then as you can see, I will keep what medications they're on. I'll keep track of when they last filled, and then that fill line I just use if they filled it or not, and then have little spots for notes, refill notes. Do I need new refills? Are they going to need a new refill soon? This just kind of helps me keep track of things as we go. And then any type of medication note. Fill location is just notes for myself to know if they need to be filled at the local pharmacy, if it's going to be shipped out to them, and etc. And then the pickup or delivery is just so I know if maybe they're coming in for an appointment and they want to pick it up from the pharmacy, they're able to get it from there instead of it being delivered. So this is just, so then I have little notes down at the bottom just for billing notes. If they're on vitamins, if they need new shipments, just different things. And then I like to keep track of when I first started filling for them, just to kind of give you an idea of how long I've been filling. Again, this is all just for myself, but I mean, somebody wanted to do something similar to this, it's very easy to customize. So as you see, some of the things I'm doing, again, is keeping track of the medications. I do call them monthly or sometimes every 3 months. If they do fill 90 days, I can keep track of refill history. And what I do is actually enter and bill everything through Enterprise RX through the outpatient pharmacy here at Primary Children's Hospital. I do not personally handle and fill the medications, but I do set up all the billing information and make sure that everything's billed correctly. And then I do keep track of the tracking information. Some of my patients, the guardians, do like having that tracking information just so they're able to keep an eye on when things are arriving. So now you can see some of the ideas and of what you can use your pharmacy technicians for, as well as kind of get an idea of my day-to-day operations working full-time in the CF clinic. So in conclusion, here's a little funny diagram I wanted to add. You can see how versatile a pharmacy technician can be. Not all of us work the same, not all of us have the same strength. But if you do have a technician, or you are fortunate enough to be able to get a technician, it would be a really good idea to be able to use them to the best of their abilities and to the strengths of that technician, as well as the needs of your center. seeing as we are all not the same and all of our centers do not work the same, do not operate the same. All of us have different needs and different wants and wish lists. So when you do get that technician, think about what would best serve your patients, serve your clinic, and of course, serve your pharmacist. And with that, I would like to conclude, and thank you for watching.
Hi, my name's Kathleen Odell, and I'm joined today with my pharmacist, Sabrina Sherwood, and we're going to talk today on pharmacy's involvement with patients' transition to adulthood and why transition is so important. There are no relationships to disclose related to this presentation. So again, hi, I'm Kathleen Odell. I've been a pharmacy technician in the Boise area since 2006. Prior to joining my CF team, I worked as both a retail technician and in the inpatient setting. I joined St. Luke's as a clinical technician in January of this year. I have both clinic duties as well as specialty pharmacy duties. For our specialty pharmacy, I serve as the liaison between our clinic and the pharmacy. I call patients to set up refills every month and work with each patient to make sure they're filling at as few pharmacies as possible. Some of the roles I have taken on in clinic are troubleshooting any insurance issues that arise for our patients, recording med histories during appointments, and sitting on our QI team to help facilitate projects. Finally, I have joined my clinic's transition team and have taken on a champion role to help coordinate all of our patients going through transition and to be their resource for questions to make their experience as smooth as possible.
Hey everyone, this is Sabrina Sherwood. I am a pharmacist at the St. Luke's CF Center of Idaho. I got my degree at Idaho State University and then spent 2 years at University of Utah. Hey Dave. So what is transition? I'm really glad that we're talking about this topic today for a few reasons, but I want to talk first about what transition is. So transition is more than just going to adulthood. A lot of people think of transition as that time around year 18 where patients are going from the pediatric center to the adult center. But really we should be looking at transitions as something that starts when the child is born, our patient is born, up all the way throughout the end of life, because we know that patients transitions at different times. I learned from all of you guys with the survey that some centers are transitioning at the age of 4. So we know that transitions is happening earlier and earlier, and we should be prepared for that. And so today we're going to talk about how you can help your patients transition effectively and really go from being a child to adulthood and managing medications effectively along the way. So first I want to start with a vision activity. So I first want you to imagine this kid on the left. So think about the youngest patient in your clinic or in your hospital or in your setting. Think about this kid as the most successful transition patient you've seen for his age. So particularly I'm thinking about a patient who in our clinic is 9 and he knows his medications inside and out. He tells his mom when he's missed a dose so that he can make sure that he's not missing another one. He's the kind of patient who I want to learn from. He's the kind of patient that I want to see what factors in his life have made him who he is. And then I want you guys to think about this patient in your own way to see what kind of things in their life has contributed to their successful transition, or at least their stage in the transition process. I also want you guys switching over now to envision the patient who you're struggling to get to transition. So for me, this seems to be a lot of the 18 to about 23-year-olds who have a lot of other social engagements going on in their life. Maybe they're in college. Maybe they've got other stressors. And for whatever reason, coming to clinic, taking their medications is lower on their priority list. So I'm thinking about a patient who we have in clinic who is 23, still doesn't know his medications, still has to come to clinic with his mother. And unless his mom brings him his medications while he does video games, he's not taking them. So these are the kind of patients I want you to think about throughout the presentation as well, to say, what kind of things can we identify about them and help them with to transition more effectively? Okay, so why are we even talking about transitions? Well, our patients are living longer, which is great. Back in 2000, the average life expectancy was around 30 years old. And unfortunately, transitions wasn't a huge part of the daily life or even the clinic life because we weren't thinking that far in advance. Fast forward to 2018, and our patients are living up to 44 years of age. And that's just going to continue to increase over time. Think about Trikafta and the difference that's made in patients living longer as well. So as you can see, transitions is going to be a huge thing that we need to think about moving forward. And today I hope that you guys gather a few ways that you can go back to your clinics and implement a transitions program.
Okay, so goals of transition. As with any project or program, it's always important to have goals set. So remember why we're doing what we're doing. The first and I think most important goal of transition is to maximize our patients' quality of life. Our patients are living longer lives than they were ever predicted to before, so making sure the quality is top-notch is so vital. Starting good habits early on in life will help achieve this. A second goal that we have is to provide high quality and individualized care. Taking into consideration a patient's developmental status as well as their age can really affect how well a patient can succeed. We all learn differently, so it wouldn't make any sense to assume one way of going through transition modules is going to work for everyone the same. There are a lot of factors that can create different barriers for each patient. So as a healthcare team, being able to recognize these barriers and adjust accordingly will play a huge role in success for everyone. Thirdly, we want to encourage and promote self-advocacy for these patients, so working with them to develop confidence in their communication and decision-making skills is so important. Helping them learn what they're asking for when they call a pharmacy or their insurance, and being able to realize if something doesn't seem quite right and being able to express this concern is so important. We have to remind patients that they're their own biggest fan, and the more they can self-advocate, the more results they will see, and their confidence in handling their complex care regimens will skyrocket. Another goal of a transition team is to promote independence, both in a patient's personal life and in taking control of their health care. We all know how rewarding it feels to accomplish large tasks successfully, such as landing a new job or a promotion, being approved for your first apartment alone, or attending college for the first time. And as patients are slowly gaining more and more confidence to take on their adulthood lives, this newfound confidence can start to cross over into their success in taking on their health care. By being their support system as a healthcare team and being there when they run into a hurdle will only help them feel more confident over time. Finally, we want to facilitate and promote a healthy relationship between the healthcare team and our patients. If our patients feel comfortable coming to us with questions and trust we are leading them in the correct direction for their transition, they're going to feel more empowered to take on these tasks themselves. Okay, so we went over goals of having a transition team, so now let's talk benefits, because who doesn't love a good benefit? There are two benefit viewpoints, one being the patient viewpoint and the other being the clinic viewpoint. So starting with our first patient viewpoint, as with almost anything in our day-to-day lives, the more you discuss a topic that may seem foreign or scary to you, the more comfortable you become with it. This is also true for our transition patients. The sooner and more frequent we start bringing up the transition expectations with them, the sooner they will become comfortable talking about everything that is involved. It will stop being foreign and scary to them and become more natural and accomplishable. A second benefit for our patients is that taking on transition can help improve relationships, not only with their peers, but their families as well. As a parent, there's endless stress of feeling like you're either pushing your child too much or perhaps not enough. Having a patient start to take initiative to take control of all things transition will ease that stress off their parents, which hopefully in turn will help the parent-child relationship blossom and flourish. With regards to patients and their peers, having a patient be knowledgeable about their disease can help ward off feeling insecure taking their medications either at school or while at a friend's house. We all know kids can ask a lot of questions about everything under the sun, so if our patient has already been talking about their medications and disease in general during clinic visits, it shouldn't seem as scary to talk about to their friends. Finally, a very important patient benefit is having the patient realize just how paramount medication adherence is. The more we can reinforce how they will feel better and less restricted in doing activities they want to do when they take their medications regularly, the more adherence will hopefully seem like a normal way of life. So switching over to clinic benefits, the first benefit is reducing the amount of emergency calls we may receive regarding medication refills, prior authorizations, or any other issue that can arise. As a team, we can show and teach patients how important it is to be proactive versus reactive regarding their medications, reminding them that since these medications are highly specialized, we have to give time to receive a refill in the mail, and calling on a Friday where you're going to run out the next day is not going to result in success. A second benefit of a successful transition team is having the clinic come across as a unified front. If we all show the patient we want the same end results and the same goals, it will be easier for them to relate and jump on board. Celebrating successes as well as working through issues are all easier and more enjoyable as a team. Finally, by having all these transition conversations slowly over time, we're going to reduce the amount of a cram session a patient might need. It will be less stressful for all involved if these tasks are accomplished slowly over time versus having a 17-year-old learn it all in 1 year and be expected to be fully prepared by their 18th birthday.
Okay, now to move on to the literature. So thank you, Kathleen, for setting the scene for us. We aren't going to have a lot of time to dive into the literature today. There are a lot of articles out there, though, that I want you guys to be aware of. In the realm of CF and transitions, it gets a little bit more sparse. But I did want to bring up today one article that was with our own Hannah Fan that was published in AJHP in 2019, which really showed that structured transition programs are beneficial, super beneficial to patients. And we're not talking just any transition program here. We're talking about ones that are established. And you know, for our clinic, that means it's through CF Rise. But today I want you guys to think about what a transition program might look like in your clinic. And it doesn't necessarily have to be CF Rise, but picking one that you can choose from, or picking one that your clinic will be able to stick to that's structured is going to be paramount. In that article that I want you to read today, or when you have time, I want you to look at her table 2 that she talks about the potential barriers. There are modifiable and non-modifiable aspects of transition, so you really should be aware of, and I just want everybody to take away the point that transitions is way more complicated than we probably will ever know, but it has to do with a lot of non-modifiable factors in a patient's life. Secondly, I wanted to talk about a 2017 article that looked at the systematic review of evidence from 43 articles. They found that transitions actually had a huge outcome component that was favorable when it was done in a structured way. So we found that clinics that had this transition program had improved adherence to care. So that could mean increased med adherence, that could mean increase in weight, or getting eye exams done. This could also look like a decreased A1C, for example. They also found that patients had an improved quality of life when they were in a successful transitions clinic or program. And then they also had increased satisfaction, not only on the patient side, but on the provider side as well. And so specifically, this article looked at more than just CF. It was mostly looking at other disease states that are a little bit more frequent. But just wanted to take away, look at these 2 articles today if you're looking to get a little bit more flame with this topic.
Okay, so as Sabrina and I prepared for this talk, we reached out to a number of teams across the nation and the globe just to see how they're handling transition in their clinic. And the best thing, the most interesting thing we found was how varied everyone was. There are clinics with full-blown, smooth sailing programs, all the way to clinics that don't have a set team or program in place. And I think this is really helpful and interesting because it just reminded us that there are a lot of resources out there that we can lean on, and we don't have to reinvent the wheel to get our program up and running. And then also as a pharmacy team, Sabrina and I decided to poll our clinic and ask them what words came to mind when they think of an effective transition program. So some of the words they come up with, as you can see, are measurable, gradual, coordinated, achievable, goal-oriented. There are just so many great and encouraging words that were thought of and submitted. And I believe that this just really shows the captured essence of what we're striving to be as a transition program.
Thank you. All right, so now you've decided you want to do a transition program. Woohoo! How are you going to assess it? Well, here are some ways. There are some validated tools called the TRACK. There's also the OnTrack and the STAR33. Just know that there are some validated measures as to which we can assess patients starting before transitioning and after to see if what we're doing is actually making any difference. The TRACK, or the Transition Readiness Assessment Questionnaire, is really interesting because it has 4 questions that are related to managing medications out of a 20-question total. So it's really a nice, quick tool that you can give in clinic.
Okay, so how can pharmacy technician involvement help? We all know technician responsibilities are growing and expanding at a rapid pace in all areas of the job. And I think having a technician on your transition team can allow them to play a vital role with patients. First off, the technician can help with medication adherence. They can explore refill histories and can assist the patient in learning how to set up refills and giving them resources to be successful at that task. There is also room for the technician to create creative ways to help a patient stay adherent, either through a medication adherence chart, talking about reminders on their phones, or reminders that they can place throughout their house to help them. Technicians can also help the pharmacist simplify medication regimens. For example, during a medication history, if the technician notices the patient on a PPI, they can ask if they're experiencing heartburn or any symptoms when they're not on this medication. If the patient doesn't report any issues, the technician can alert the pharmacist to possibly discontinue this drug and lessen the medication load. Additionally, the pharmacy tech can help identify any issues that seem to be arising early on. He or she can alert the pharmacist or transition team if they notice the patient is struggling in one certain area. For example, not understanding specialty pharmacy versus non-specialty pharmacy, lacking the confidence to place a refill call or a call to their insurance, or even feeling uncomfortable to request help in getting replacement nebulizer items. If the pharmacy technician can identify this and bring it to the attention of the correct discipline, they can all work together to help brainstorm ways to aid the patient in succeeding and even tailor a plan specific to that patient that will help ensure success. So I wanted to talk real quick about my personal contributions to the transition effort. So as a member of my transition team, I've tried to extend my efforts as a technician any way that I can. I recently joined 2 other team members in taking on the champion role for the CF Rise program. And while this is still a new development for us, I'm hoping to gain as much insight and knowledge into the program as I can. I also play a part at the specialty pharmacy liaison, which has helped me develop personal relationships with our patients and create a bond with them. By being allowed to work at the top of my license in all areas of my job role in clinic, it's allowed my pharmacist to have more time to excel at the top of her license and take on more clinical roles as well. So how can pharmacy involvement grow? The biggest thing I notice with transition teams is that there's so much room for pharmacy technician growth and involvement. There are so many roles that the technician can take the lead on and free up the pharmacist's time. Then they'll only really need to involve the pharmacist when they have to or at vital emergent times. I think every team should utilize a technician as much as possible. Another area I saw for pharmacy growth was the area to develop streamlined processes that are tailored to each clinic. This is something a technician can also take the lead on because there are a lot of resources out there, and by narrowing it down and streamlining it to fit your clinic specifically will definitely yield great results.
All right, so what are some steps that you can take today to get started on this? I want to provide you with just a few. First, I want you to start a transitions committee in your clinic if you haven't already. Take the lead, get it going, and then identify 2 or 3 transition champions who can really take on the task of developing this program. So for instance, ours includes Kathleen, so pharmacy technician, a social worker, and a registered nurse. And then our whole clinic helps, but they really champion it. So identify those people. And then select your transition program. So we've talked today about CF Rise, but that's because that's the one we're familiar with most. Feel free to look around, see what other places are doing, and really decide for yourself, do you want to use a structured program or not? The most important thing is just to get going and then see how things go and see how much this is going to improve your patient's care. So in conclusion, we hope that today you took away that transition programs are important and needed as our patients are living longer and longer. We see that there's huge opportunity for growth in pharmacy with this area, especially pharmacy technicians. And I want to encourage all of you to use your pharmacy technicians to the top of their license to really help our patients in this very important part in their lives. So thank you all. Here's our contact information. Please feel free to reach out. I've got tons of stuff to share with you about transition. So that's all. Have a great day.